Today, we will have a presentation that many of us have been really interested and anxious to hear for some time, and I'm excited to have this happen today. We'll have two speakers who I'll introduce to you in a moment, really addressing the new technology that's available in diabetes care, what you need to know, which will be our first speaker, Dr. Bruce Bode, followed by Dr. Georgia Davis telling us how we can actually use this technology for underserved populations. And I think, again, really complementing the first part of this. So Dr. Bruce Bode is a clinical associate professor in the Department of Medicine here at Emory, and he is also CEO and president of Atlanta Diabetes Associates. He completed medical school and residency at Emory and did his fellowship in diabetes with Paul Davidson. He has written over 300 articles and books in the field of diabetes and is considered one of the leading experts in the world on insulin delivery, glucose sensing, and the development of automated insulin delivery systems, both at home as well as in the hospital. He's very active in clinical research for new diabetes products, including pharmacologic agents to prevent diabetes and control glucose with new insulins and glucose sensors. He will begin, and then I'll have him hand it off to Dr. Georgia Davis. Dr. Georgia Davis is an assistant professor of medicine at Emory. She completed her medicine residency at Case Western Reserve University Hospitals and her endocrinology fellowship here at Emory. Her research focuses on inpatient and outpatient glycemic management, including the use of diabetes technology and its applications to diverse patient populations with dysglycemia and diabetes. Her clinical practice is based at Grady, where she leads a clinic dedicated to managing type 1 diabetes and improving technology use among those with limited resources. So you can see, I think, that these two speakers will beautifully complement each other and will give us an introduction to what is really new and fast moving that I, for one, have not been able to keep up with over the last decade of changes. So thank you both very much, Dr. Bode and Dr. Davis, for presenting, and I will turn it over to you, Dr. Bode, to lead off. As always, please feel free to put questions in the chat, and I'll moderate a question and answer session in the time remaining at the end. Dr. Bode?
Okay, thank you. It is an honor to come and speak to Emory Grand Rounds. Obviously, we're now 100 years from the discovery of insulin back in 1921, and as you can see, the technology didn't really start until really in the 70s with a Ames reflectus meter, which was the first ability to have using a finger stick. And right shortly thereafter, there was work being done on insulin pump therapy. And at that time, it was back in 1975, I was up in Cambridge working on a insulin pump at that time. I had graduated from college in 75, and I returned back to my home. Unfortunately, early in my life, my grandmother came to live with me. She had type 1 diabetes, and she was in Ohio, and my father brought him over to Boston to be in Joslin. And all I remember is having my father sharpening needles and boiling syringes, and I said, that's the last disease I ever want to see. And unfortunately, but fortunately, I actually went into diabetes after finishing my internal medicine in '85. I followed with Paul Davidson, who was my mentor, and during this time, in '85, I actually put in my first year, I put 125 people on insulin pumps then. And then I followed all of my patients and published all of that data, which at that time became very significant on the benefits of insulin pump therapy. And then ever since then, I've been in diabetes technology. I was the first person ever to write publish anything on continuous glucose meter that came out in 1999 by MiniMed. And then I've been involved with all of the hybrid closed loop systems as well as other issues with type 1 and type 2 diabetes. So I'm going to talk about quickly the glucose goals. talk about pens, pumps, and sensors in the US. Also talk about artificial pancreas, which is now where it is, and then I'll end with what's happening in the future. Obviously, the goal is trying to get under 7%. You would like your pre-meal to be from 80 to 130 and post-meal under 180. And you really want to prevent hypoglycemia at all costs. And so now, besides just getting an A1C under 70, 7.0, you want to have your target range of glucose measurements, whether it's 4 tests a day or using a CGM. You want to be greater than 70%, between 70 and 180, less than 4% under 70, and less than 25% above 180. So these are the new, this is the new measurements on looking at how to really determine if somebody's doing well or not. This is data from the T1D exchange. We're part of one that we follow about 29,000 people with diabetes. And as you can see with type 1 diabetes, especially in adolescents, they don't do very well. And after about 20, 25 years old, their A1C average is about 7.5. People with type 2 diabetes on insulin, over half the people on insulin with type 2 have an A1C above 9%. So we're totally failing using what's happening now. And the other big issue with diabetes, especially type 1, and if you start pushing your glucose to near normal, you have an increased risk of hypoglycemia. And in type 1 right now, there's an average of one person having a severe hypoglycemia each year, especially if you're above age 50. And unfortunately, the risk of dying from hypoglycemia is still happening in type 1. About 10% of people will die from hypoglycemia. And so when we looked at this and we said who really does well, these are people with type 1 with taking insulin. This is also true for type 2 if you're on insulin. And if you're going to try to get under 7, you do better with insulin pumps. You also do much better wearing a CGM or testing the sugar 4 to 6 times a day. If you bolus before you eat, you do much better than after you eat. And if you know how to manage your glucose with a meal by counting carbs or measuring what's happening, they do much better. And as you know, continuous glucose monitoring first came out in 1999. In 2016, the Endocrine Society and the American Association of Clinical Endocrinology said if both for type 1 or even type 2, and if you don't know what's causing the A1C to be high, you should put them on a CGM. And then 2018 has also adopted this. And now Medicare, if you're on any mealtime insulin, either type 1 or 2 or type 2 or atypical diabetes, Medicare will cover a continuous glucose meter. And this is data from 2018. If you were on a pump back in 2018 in our registry, about 40% of people were wearing a CGM. But if you're on just injections, only about 8 to 10, 15% were wearing them. But now because these sensors are getting so much easier, it's almost doubled that in the past 3 years. There's only 3 glucose monitoring systems approved in the US right now. There's 4 more that are interested coming into the US. The first one was Medtronic or MiniMed, and they both have it connected with their pod, with their insulin pump, as well as standalone, the Guardian Connect, and that uses Sugar IQ, which will eventually automatically adjust your basal and bolus accordingly if you put the data in there. It's always, all of these are on phones, whether it's Apple phone or any other phone. And then the big change is when Abbott Libra came out. We did all this work using Abbott Libra and Navigator. It's a simple little size of a quarter, and it goes in. It's totally testing a glucose every 15 minutes, and it has no calibration. You can't calibrate it, and it lasts 14 days. You can either scan it with your phone or you can scan it with a reader, and it shows up, and obviously it's very easy to use. Libra 2 has also been launched with alerts, and Libra 3, which is continuous glucose monitoring, is available in Europe, but not here at the time. And Dexcom then has also come in, and they were the third player. It's a very small wired enzyme that goes underneath the skin. The applicator is very easy. You just push the button down and it goes down very easy. You then attach a transmitter, and that transmitter will last up to 3 months, and then you have to get another transmitter. And then you can see it either on a receiver if you want, or just see it on your any type of phone you want to use. And so obviously they also it does not need any calibration, but if you want to calibrate it, you can. And overall, all of these sensors have improved dramatically since 2006. The mean absolute relative difference between a YSI has gone down from 26% to now 9%, both with Medtronic as well as Abbott's approaching to about 10%. In the benefit that what Dexcom's done is they're connecting with Tandem, and they're also connecting with Insulet, the OMNIPOD. They're also working with smart pins and so on. And then there's another implantable sensor which has come out, Senseonics. It's only 90 days here. It's put directly underneath the skin. It's an optical sensor. It's extremely accurate. The MARD there is between 7.5% and 8%. We have just finished the 180-day trials, and that is being submitted to the. It's under the FDA right now. In the rest of the world, it's been out for 6 months for at least 2.5 years. It also goes on a mobile app, and there's a transmitter, and it's a very easy insertion, and it's easy to insert. It takes about 3 to 5 minutes. Take it out, 3 to 5 minutes, and it's later this summer we're going to a one-year sensor and trying to validate that. The reason why people like this, people don't want to wear anything on their body often, and if that's possible, it's like cardiology. The pacemakers have all of those have been implanted, and why not put a sensor in with a battery and then just sending it off to the phone? That'll be there in the future for sure. And there's data that across the board, both from Medtronic as well as Abbott, as well as Dexcom. If you wear a glucose sensor, you drop it 0.4 to 0.6%, your hypoglycemia can go down dramatically, and time and range is increased dramatically. So we did a trial taking the Abbott Libra, and we wanted to work with Glucomander outpatient. As you know, we were the developers of IV Glucomander and sub-Q, and we wanted to see if we could use Abbott Libra and would it work instead of pricking your finger. And then so what we did here is we wanted 25 patients with type 2 diabetes on insulin with an A1C above 8%. On average, their A1C was 11.4%. We then asked them to, if they had a phone, and then either an Android or an iPhone, and if you had the app, we would give them an Abbott Libre for free, and then we would set them up, and we would do 4 titrations over a 6-week period, and seeing how much better they will do. In this, it was automatically done. The glucose went directly into Glucomander, and it spit out a breakfast dose, a lunch dose, a dinner dose, and a bedtime dose. And it was done once a week. And it went from time and range from 48% to 74% over 6 weeks, with no intervention of a healthcare provider other than an educator that is putting this data in and then texting it back to the patient itself. So it works very well. In this case, at baseline, you can see their average glucose is above 180, and it's going anywhere up to 400, but very little hypoglycemia. And then it comes down, and it came right down to 150 just using algorithms to adjust once a week. And it was very successful. Your time and range increased dramatically, and up to over 70%. And overall, as you can see, the improvement was dramatic, looking at the A1C and also looking at the CGM itself. It's very tight, and it's average below 150, and having very few above 250, and almost zero below 70. So it's obviously able to do that, and this is going to be the future going for MDI in the future. You put a sensor on, and then it follows you, and it follows both the insulin going accordingly. And so what's coming out, and this was developed by Companion, it's called Companion, out in San Diego. This was purchased by Medtronic. It's a smart pen. It lasts 12 months. It is compatible with Novolog, Humalog, and Fiasp in cartridges. You can have half unit or 1 unit. It tracks active insulin. It reminds to dose. It calculates personalized dosing for them. It automatically logs the dosing. So if you aren't using it, they can tell you you miss your dose and so on, and you can share it with anyone. And it's all on your phone. You see it, and it's Bluetooth. It's right now available for both the Dexcom G5 or G6 or the Guardian Connect CGM, and it's indicated for any ages, except if it's under 7 years old. You have to have a caregiver supervising this. And so this is FDA cleared. And the reason why this is so important to come out is missing 2 doses a week can lead to an A1C of up to 0.4%. 2 out of 3 people need help calculating their insulin doses, especially people with type 2 diabetes. And 60% of insulin doses are taken with some insulin on board, and that causes hypoglycemia. And the lack of accurate dosing data is a significant barrier to optimizing glycemic control. So you really need to have artificial intelligence to do all this. And so it'll tell if you missed a meal dose. If you missed your long acting, it'll tell you. You have to set it up on your app. And if you didn't put a blood glucose in, it'll remind you, and it'll also tell you when you're running out of your insulin. And so you can do carb counting if you want based on grams. You can do missed meal estimation, whether it's breakfast, lunch, or dinner, or small, medium, and large, or you can do just fixed dose, and just saying, I'm eating. It doesn't matter. And obviously using a bolus calculator is associated with a 0.7 to 1% reduction in A1C. And that's the benefits of insulin pumps when that came out with this bolus calculator. It's something we actually developed back in the mid 1990s. And so obviously you have all these options. You can change if you have a different carb ratio at each breakfast, lunch, and dinner, you can do that. You can change your sensitivity factor, or known as a correction factor. You can also change your target. If you're worried about going low when you're exercising, you can bring it up and it'll tell you what to do. And obviously, this stacking is very common with people with type 1. You know, they're trying to chase. Even in type 2, you're doing terrible and you take more insulin, and the next thing you crash and you're comatose. So obviously, this is totally avoided. And so you can easily, it's always on the patient's phone. You can share it. You can also download it. And we do this all the time to our educators. We download it, we look at it, and we help them better manage their diabetes. So this is a simple, this person has 6.3 rapid doses per day. Their average glucose is 222, so they aren't doing too well. They missed 35 doses probably because they weren't eating breakfast. And they're only using their calculator 41% when they're giving insulin, so that's not good either. And they aren't recording their basal. It's, however, they say they're taking their basal. But here, there's targets 120, carb to insulin ratios 8, correction factor 35, 40, and 35. And then you can see here on the upper left-hand side, your fat, you went to bed at 216, you woke up at 171. A lot of people say, hey, well, why don't we give them more basal? Well, that's a disaster. If you drop more than 30 points to 40 points from bedtime to breakfast, and you start pushing your basal, you will cause hypoglycemia. So you want to prevent that. It looks like they certainly aren't covering lunch and dinner. It's not doing very well. So then you look at this further, and if you look just from midnight to 6 a.m., the first day she's high, second day she's normal, third day she's low, fourth day she's slightly high, and the next day she's slightly low. That means she has too much basal. And her problem is, like on Friday, July 12th, she actually missed her donut, her breakfast dose completely. So she needs a lot of help. And that's when it comes to these hybrid closed loops. These hybrid closed loops are out there. It's a sensor feeding it directly to an insulin pump. And the indications of these pumps are if your A1C is not at goal, your glucoses are going below 70 or above 180 consistently, or you have hypoglycemia unawareness or history of severe hypoglycemia, or just because you need a flexible insulin regimen. And so there's only 3 pumps now, when back about 10 years ago, there were actually almost 7 pumps, but obviously there's only 3 right now. There's a fourth coming to the market. But in the far left-hand side is Medtronic hybrid closed loop. In the upper is Tandem. In the lower is Insulet, known as OMNIPOD. They're all of them work. All of these systems are talking to a sensor back and forth and controlling it and trying to get time in range below at least 70% in time and range. And so the first one was back approved in 2015, the 670G. And at this time, the only thing you could do is enter a glucose, and the healthcare provider can change the carb ratios and active insulin time. Otherwise, it was automatic. And all you cared about is this shield. And during this pivotal trial, there was no control group because the FDA doesn't care about a control group necessarily. They look about safety. And they went from 7.4 to 6.9 with 0 hypoglycemia or ketoacidosis. So it worked very well. And we did kids, and they went from 7.9 to 7.5, again with no hypoglycemia and no ketoacidosis. So it worked. And then in real life, you look overall, they're 72% time in range in real people. This is 70,000 people after the first year had already been on this. And if you weren't using automotive, you're only on 61%. You also have less hypoglycemia. So obviously it does what it's supposed to do. So this is a patient who's 74, and this is before she's been a patient of mine. She was on a sensor augmented pump, but it wasn't hybrid closed loop. So that's in the brownish area. Overnight, when she went on this, she's perfect overnight. She wakes up 120. She's somewhat demented, so sometimes she misses her dose, but rarely does she die. She keeps telling me she misses it, but when I look at it, she is taking her dosing accordingly. So her average glucose is doing very well. Her sensor's 155 and her A1C is down to 7.6 and without a problem. Here's a type 2. He's a patient that I've been seeing for 10 to 15 years with bad cardiovascular disease. His A1C when he came to me was 12. I got him down on a pump and I couldn't get him under 8.5. And now I put him on this hybrid closed loop and he's 74% in time and range with no severe hypoglycemia, and his A1C 7.3. Type 2s are easier to manage than type 1 using because there's little risk of hypoglycemia. However, in doing this, if you don't follow instructions or you're scared of going low, you get kicked out. And this was, FDA put a lot of these issues on. And so in her whole problem, she's only 38%. She's A1C of 8.4. She's not doing well. She keeps getting kicked out because the glucose keeps going high in the shaded area here. You can see when it's dark shaded, that means she's kicked out. And the FDA put all of these issues in with this because this was the first artificial pancreas that has come out. And so what happened is many people had too many alerts. They had to check their sugar 3 to 4 times a day. They had to put the carbs in. They had these guardrails that FDA put in. If your basal's below a certain amount, it kicks you out. If it's maxed out, it kicks you out. If it's glucose going up, it kicks you out. If it's going low quickly, it kicks you out. And the target was only 120. So since then, we've done another version of this. It's called Advanced Hybrid Closed Loop, in maximizing time and range with both a target of 100 or 120. And again, instead of just adjusting basal, it's adjusting the bolus also. So it's an auto basal, auto bolus correction. And in this case, again, they get down to 7.5 to 7.0. Most of these people were already on another pump, and they could even be on 670, and they did so much better. And then when you look here, the green is time and range, and you can see in adults, they have 75% time and range, which has never been seen before. And the overall group was 74%. So it works with very little risk of hypoglycemia. And so obviously the average A1C went down, from 7.5 to 7 without an issue. And if you used if you went down to a target of 100 with your time in range was 79%, but a lot of people are scared of going down to a target of 100, so some prefer to be just safer. But there was no difference in hypoglycemia between 100 or 120. And so the thing they're going now is using, they're launching 780. It's before FDA right now. It should be approved in the next few months. You can go to this. There's only one calibration for the first day, and that's it. They have an extended wear infusion set that lasts 7 days. And then we're also doing personalized now using artificial intelligence. So it comes back and it tells you how to change your carb ratio or your meal dose or your active insulin time. And during this time, we're telling people we'll tell them is we don't want you to cover breakfast for the next week with any insulin, but keep eating breakfast. And at the end, it's totally controlling their glucose automatically. This is still in the works. It's probably another 1 to 2 years with this advanced. There's others. Tandem has been very successful. It has no calibration because they're using the G6. It also has automatic correction bolus once an hour and also auto basal. And it's very, very successful. And if you put it in sleep activity, you're at 110 to 120 every time in the morning, no problem at all. If you exercise, it'll bring you up to 150 and protect you. And it's very easy. This system went through NIH. NIH sponsored all of this. And so they had a control group, which is great. And that's what you really want to do in science. And overall, they went to easily 71% versus 61% time and range. So that was very successful. They looked at, and it was so easy to use. Everybody could use it. They're between 4.5 and 4.8. So it was easy to do. And then looking at real time, it's in the trial, it was 71% time and range of 112 patients. And with pediatrics, there were 67% in their trial. But in real world, when they started using it, was 77%. And in their 92 to 93% in auto mode, so which is dramatic. And then the last one I just want to show you so we can get back is looking at the horizon. This is a study where you have a pump is disposable. All of the artificial intelligence is in that pump, and it's talking to a Dexcom G6. You can target between 110 and 150, and it's an algorithm that will make a decision every 5 minutes. So this is the pre-Vita study. The FDA asked us to do a study both for kids and adults, making sure it was safe over 3 months to make sure. And so we did this trial. And again, if you had a target of 130, they had 75% time and range. If it was 140, it was 68%. And if it was 150, it was 64%. They wanted to tell us exactly, they wanted us to do these every 3 days, and it worked very well. And then now in their 14 to 70 years old, they're at 74% time and range, and that means their A1C will be below 7. There's almost no hypoglycemia. There's no severe hypoglycemia, and it worked very well. And here's the children, 6 to 14, they were at 70% time and range. All of this data is going to be published. It's all been finished, and it's going to be submitted in the next 2 weeks at Endo Society. So that's coming out. You can also do it yourself if you want with both OMNIPOD as well as Medtronic pumps. And this is coming out of Silicon Valley. There's people developed their own artificial pancreases, and they're very, very effective. So that's there. And the last thing is, do we need a second hormone, glucagon? As you know, islet cells or beta cells are giving out insulin and amylin, and alpha cells are giving out glucagon to prevent hypoglycemia, and delta cells are putting brakes on both insulin and glucagon. So obviously, we're starting these trials this coming summer, and this will last over the next year, and see if you can. Is this going to be better using glucagon with insulin? In this case, all you do is put your weight in. You don't have to do anything else, and off you go. And from there, it'll operate continuously. So I'm going to stop here. And obviously, technology is rapidly developing. CGM is standard of care, including smart pens will be in the future. And obviously, it's easy now to manage diabetes, and hopefully we'll enter in the type 2 space using these systems. So thank you so much.
Okay, I think we'll take over the screen.
Yeah.
Can everybody see?
Yes, perfect.
That was an excellent talk, and I'm Georgia Davis. I'm really excited to be here today as well to follow Dr. Bode's presentation on the incredible updates in diabetes technology. Again, I know that my clinical practice is based at Grady, where we treat many patients from diverse racial and ethnic backgrounds, and also really variable socioeconomic status situations. So today I'm going to take a little bit of time and talk about how diabetes technology fits in underserved populations, and a little bit of history around the use of technology in these situations. So first, we'll just briefly review today the disparities that exist in glycemic control, diabetes-related outcomes, and also, again, the use of diabetes technology. So like Dr. Bode had discussed in his presentation, we know that we've seen these impressive developments in what's available to help patients with diabetes control their sugars and achieve those really great glycemic control metrics. We know that the use of insulin pumps and CGM can improve glycemic control in both patients with type 1 and type 2 diabetes. But much of the data on the disparities here in technology use comes from knowledge of type 1 diabetes in younger populations. In this screen, we know that disparities in glycemic control and diabetes-related outcomes are well known in these younger populations with type 1, and they've persisted for a long time. You can see the dates here date back to the 1990s. This slide summarizes glycemic control and diabetes outcomes from these prior studies in youth with type 1 diabetes by racial and ethnic groups. We see that non-Hispanic Black youth consistently have worse glycemic control by A1C, and they also have higher rates of DKA. And this is compared to both the white and Hispanic youth. For example, if you look at DKA here, we see that there's a threefold higher rate of DKA in Black patients compared to white patients. When we move down here to mortality, and we look at diabetes-related mortality specifically, we see that there's really not that much recent data. However, this study in 1999 by Lipton and colleagues out of Chicago showed this higher annual case fatality rate in Black youth. And also in that paper, there was a discussion that there was a threefold higher risk of death for Black and Hispanic children with type 1 diabetes compared to children of the same racial and ethnic background without diabetes. Whereas non-Hispanic white children in the same cohort with and without diabetes had the same risk of death. So knowing that these disparities in outcomes exist, it's also important for us, I think, to discuss the disparities in diabetes technology treatments and how the use of the technology can impact glycemic control as well as socioeconomic status. So this figure shows data from two different large registries of participants with type 1 diabetes from two countries. So the Diabetes Prospective Follow-up in Germany and the Type 1 Diabetes Exchange here in the US. And it's actually over two different time periods. So an earlier time period from 2010 to 2012, and then 2016 to 2018. The top figures here show that the use of insulin pump therapy in both cohorts along these socioeconomic quintiles. So you see on the bottom, everything is distributed through socioeconomic quintiles, with the lowest socioeconomic status reflected in Q1, the highest in Q5. So among all of these quintiles, insulin pump therapy has increased, especially in the US here. And I think you guys can see that, hopefully. But really here in the US, the increase in pump use predominates in the wealthier quintiles. Whereas in Germany, it's sort of a contrast where we see insulin pump use distributed more evenly among the socioeconomic status quintiles. This really shows, I think, the difference between, two healthcare systems and how we provide access to care for our patients and technology use, especially with insulin pumps here. So there's been like Dr. Bode mentioned, there's been a remarkable increase over the past several years in continuous glucose monitor use, which is reflected in the bottom part of this graph. So really everywhere we see from 2010 to 2012, the rates of use were much lower for CGM, and they have really picked up starting in the later years here. And this happened in both countries, but again, the uptake of CGM use in the US has really increased again in the higher socioeconomic groups. This next figure is reflecting glycemic control in the same cohorts. So there's really a negative relationship between A1C values and socioeconomic status in both countries, but the magnitude of this relationship is much more pronounced within the US. So those with, the lowest amount of resources have the highest A1Cs. And again, at the opposite spectrum, the more resources you have, the more likely it is that you can afford those things that can help you control your diabetes in a better fashion. When we look further into the disparities, I think in technology use, we see that also racial and ethnic background may play a role in the decision of which treatment modalities are used for diabetes care. This figure shows insulin delivery methods among white, Black, and Hispanic youth in type 1 diabetes across different age strata. So 1 to 6 years, 6 to 13 years, and age 13 to 18. The bars here in the middle show different modalities of insulin delivery, with the white section being insulin pump, Black section being multiple dose injections, and then the shaded section here, fixed dose insulin injections. So in all groups, we notice that both Black and Hispanic children have a much lower use of insulin pump therapy, with actually the lowest rates among Black children ages 6 to 18 years old. And these disparities actually persisted when they adjusted for different socioeconomic factors in this data. This slide is going to refer to the young adult racial disparities in type 1 diabetes study, known as YARD. This is a population of 300 participants that targeted inclusion of minority populations, with about 100 participants in each group of Black, Hispanic, and white young adults. And they were ages 18 to 25. And this was really targeting information to obtain information on socioeconomic, disease-specific data, and also a better understanding of social determinants of health that impact glycemic control. So this figure shows again here that insulin pump and CGM use is lower in Blacks in the young adult population, despite adjustment here on this side, so unadjusted, and despite adjustment here that was made for socioeconomic factors. What's interesting is that we see when we adjust for those socioeconomic factors, the lower use that's observed with pumps and the unadjusted CGM use in Hispanic population sort of equalizes here, but the difference in the lower use persists in non-Hispanic Black youth. So an additional analysis from this population showed a large disparity in glycemic control. So here we see between white and Black participants that there was a 2.26% difference in average A1C. And the proportion of this, and there's different contributing factors to what's in that disparity as to why Black participants have a higher A1C. Again, most of it can be explained by socioeconomic factors. We know that that's not unexpected. Fortunately, treatment regimen, and that includes the use of insulin pumps and CGM, also plays a big role, as do other things such as psychosocial factors such as diabetes, distress, self-management, efficacy. But there's still this big unexplained portion of factors that we don't know that are contributing to worse glycemic control in this population. And I think the next slide, I'm going to transition a little bit. We'll talk about COVID-19 and how things have changed for everybody, including, our population here at Grady. And we're seeing, again, that huge uptake in CGM that was over the past, 2 to 3 years, but sort of also increased in the wake of COVID and the development of remote care possibilities. So this really included CGM, which is here I have here that, Medicare started increasing access and providing coverage for CGM, especially during COVID. And I know that Abbott here also decreased the cost of their Freestyle Libre sensors to try to increase access for a lot of patients. And this, we've been working on increasing access here at Grady, both in the outpatient and the inpatient settings. Although, CGM access has increased a lot, there's a lot of folks here that even with the discounts, the financial requirements to get the technology is just still too much. So I think it's something that is important as we go forward and the modalities of care change within the wake of the pandemic. This is a slide that shows we actually implemented CGM use with the Dexcom G6 in the ICU here at Grady. To provide remote glucose monitoring for our ICU nurses and staff who were using Glucomander, which Dr. Bode talked about. So the algorithm for insulin infusion, the hourly insulin infusion for patients requiring insulin drips. So we combined that with the Dexcom continuous glucose monitor and with a protocol that still used point of care testing to ensure accuracy of the CGM, but to try to decrease the amount of times the nurses had to walk into the room to do just a point of care glucose test to adjust the IV insulin rate. So we're working on increasing all of these things, especially in our populations that have historically been underrepresented in a lot of this diabetes technology and the research and the care. And we are working on outpatient access as well, especially with the CGM here in our dedicated clinic for diabetes technology and type 1 management. So in summary, disparities, they do exist in glycemic control and outcomes, and race and socioeconomic status are often big components of these disparities. Inequities exist in diabetes technology that continue and persist despite increasing or decreasing cost of the technology over the years. So continued efforts are needed really to help our patients who don't have as many resources as some of the others get access to the devices and the care that they need to really improve their glycemic control and prevent complications and poor diabetes-related outcomes. And that's all I have today.
Thank you. That was fantastic, both of you. I'm really grateful. We have a few minutes for questions, and I'd like to pose a couple that have showed up in the chat. Dr. Bode, first off, Dr. Olson asks, most internists have limited exposure to this explosion of technology. What are sort of the key messages to internists? What do they need to know? Like, who do they refer, or how do they get access, or what are the things that an internist needs to know to implement some of this?
Yeah, I think the one thing they can do is obviously, if people are not well controlled, I think you probably need to refer to a group that can manage it. But I think the one thing they can do is always put on a sensor on. You can either use a Libra or a Dexcom or even a Medtronic, and all of them are willing to give samples to anyone to let them try it. It doesn't cost anything to try now, and then you can see them back. But if they don't understand how to interpret it, it's pretty easy. But I think in the long run, the artificial intelligence will do all of this for us. So if you put a sensor on them, it'll tell you exactly what to do and what the next steps to do. In doing closed loop, a hybrid closed loop in the future, it's going to be very easy to the patient. You just put it on and go with it, and then you can remotely manage these people anywhere in the world. It's very easy to do that and manage them. So I think what the internists in the family practice need to know is that you have this technology. Find out what their glucose is doing. Are they going up or down? What is their time in range? Are they really greater than 5%, below 70, and so on? Obviously, in the hospital, using Glucomander, it's perfect. It will always control glucose all of the time using artificial intelligence. These algorithms are very good.
Yeah, to me, it's really pretty mind-blowing. My question was, when you showed really great data from study populations looking at even adolescents, which are, classically the hardest group to control with these devices, is real world application the same because they are so automated, or is there a difference, when you have perhaps not a study population, but a potentially more challenging population?
Yeah, I mean, obviously, unfortunately, a lot of people are not interested wearing anything on their body, and that's even wealthy people and other people that are very poor. They don't want anything on their body. So in the long run, you're really going to need to go into implantable pumps and implantable sensors. If you need a pacemaker, back when I was working at Grady in '70s, and there were no pacemakers then. It was all outside the body, and then obviously everything changed. And I think that's feasible with the future doing this. But in the meantime, all of these are going to get much smaller. You just put it on. It'll be a pump and a sensor all in one. We're doing some work starting in the next week, and we're able to use a sensor in the infusion set directly within 8 millimeters. And will that work? That'll make it easier. Just one place to put it in instead of two. And then eventually you could just do it with a pod itself with an insulin and a sensor. It'd be easy.
Amazing. Dr. Davis, there's a couple questions about sort of access. Do you have any data on CGM modalities for the Native American populations who have been disproportionately affected by diabetes, or how access looks with Indian Health Service? And then as another part of that question, I also was curious if that insulin costs, which I've heard about being so challenging, add to the challenges for more vulnerable populations with this.
Yeah, so there are a lot of challenges, and I actually haven't seen data in Native American populations. I'm less familiar with that. There may be some, but I have not seen that dedicated in terms of CGM modalities in that population. The question also asks about IHS as a payer, and I'm not familiar with how much they cover. So a lot of things that we run into here, even with government insurance programs, sometimes they're extremely affordable. So we'll have patients, receive CGM through Medicaid plans, and the copay will be nothing or close to, and something very affordable that they can do. But a lot of times with Medicare, the copays can be a lot higher, and it's something that's still cost prohibitive for those, you know, in the lower resource settings. You know, with again, with IHS, I think it's variable, and it just depends on the patients. In terms of insulin access, it's very similar. So a lot of patients are facing really diverse problems with getting the supplies and medications that they need, and it makes things difficult. We're asking a lot for people to be creative and asking assistance programs from, you know, a lot of the pharmaceutical companies to help us get access for some of our patients here who, you know, aren't able to utilize the county coverage system. So there's a lot of creativity that goes into some of it, you know, and patients who also pay for, you know, these marketplace plans that have deductibles that are extremely high run into a lot of issues. So there's very nuanced issues that happen for a lot of folks, but that's a great question. Actually, I think that we really do need to focus on, you know, our at-risk populations.
And I'm sorry, there's a ton of questions and we are out of time. I'm going to ask you, Dr. Davis, just a really quick one. For those managing grade E patients with Medicare, Medicaid, how do you refer them? Who should they be referred to?
Yeah, so far it's us here in the diabetes clinic, but we're working on protocols and increasing that access and educating our colleagues on how to do it. It's a little tricky sometimes with the paperwork and managing, but we're hoping that we can involve everybody. But so far we're trying to work through that here in the Diabetes Center.
Great. Well, sadly, we are out of time, but thank you both. This has been really, really fascinating, and a look to the future where it sounds like this is going to be pretty likely widespread use as time goes on. But thank you very much for this terrific talk. And for everybody else,
thank you.
We will see you next week.